Imagine waking up one day and the world is just spinning, like uncontrollably.
Yeah.
Your hearing's cutting in and out, almost like a faulty radio. You've got this constant ringing in your ears, and there's this weird kind of overwhelming pressure building up in your head.
Mm-hmm.
It sounds like a nightmare, but it's not. For millions, this is the baffling reality of a pretty puzzling inner ear condition.
It's a really profound disruption, you know. It affects hearing, sure, but also balance, and it often just hits you out of the blue.
Sounds incredibly tough to deal with. So today, we're doing a deep dive into Meniere's disease. It's also known as endolymphatic hydrops, right? And our mission for you today is to unpack a really detailed medical text about it. We want to take all this complex info and make it super clear, really insightful.
Sort of breaking it down.
Exactly. You're basically getting a shortcut to being properly informed about Meniere's. We'll cover everything from the tiny details of the pathology right up to how it impacts daily life and, the fascinating ways science is trying to help.
We'll be pulling out the key stuff, the surprising facts, those aha moments, basically giving you a comprehensive picture without you feeling overloaded.
Yeah. No jargon overload, hopefully.
Right. And by the end of this, you'll not only get the ins and outs of Meniere's, but also, I think, really appreciate just how delicate that inner ear balance is, how tiny changes can have such huge effects.
Okay, let's get into it then. At its core, what exactly is Meniere's disease? And what are the absolute classic symptoms someone might notice?
Okay, so fundamentally, it's a disorder of the inner ear. You have this delicate closed fluid system inside called the endolymphatic system.
Right.
In Meniere's, the system gets distended. It's basically overfilled with this fluid called endolymph.
Hence the hydrops part of the other name, endolymphatic hydrops.
Exactly. Hydrops just means fluid retention. And the condition usually shows up with 4 key symptoms, the cardinal symptoms.
Okay, what are they?
First, vertigo, that intense spinning feeling. Second, sensorineural hearing loss, meaning hearing loss originating from the inner ear itself. Third is tinnitus, which is that persistent ringing or maybe buzzing sound. And fourth, oral fullness, just a feeling of pressure or blockage in the ear.
So it really is all about that fluid balance getting messed up.
Mm-hmm.
And what's actually going on inside the ear structure when this fluid builds up? What's the pathology look like?
Well, when you look inside, the main issue is definitely this distension, the swelling of the endolymphatic system. It mostly hits the cochlear duct, that's the hearing part, looks like a snail shell, and the saccule.
Oh, saccule, what's that?
It's a tiny little sac that helps us sense gravity and linear movement, like going up in an elevator. To a lesser extent, it can affect the utricle, another balance sensor, and the semicircular canals, which detect head rotations.
It's pretty wild how the source describes it like this tiny membrane, Reisner's membrane, bulging out so much it might even push through little gaps where it doesn't belong.
Yeah, it's quite dramatic language, but it captures the idea. It says it might herniate through the helicotrema into the apical part of scaleotympany. It's a big physical change. And that distended saccule we mentioned, it might end up pressing right against the stapes footplate. That's that tiny little bone that transmits sound vibrations.
Okay, and I guess that abnormal contact explains some things later on.
Exactly. We'll come back to that. You might even see little outpouchings, like tiny balloons from the utricle and saccule pushing into the semicircular canals. It's all under pressure.
Okay, so we get what happens physically, but the million-dollar question is why? Do we know the exact cause?
Unfortunately, no. The exact cause isn't fully pinned down yet. But the main theory, the core idea, is all about having too much endolymph fluid.
Right.
This could be because the part that makes it, the surda vascularis, is overproducing, or maybe the part that absorbs it, the endolymphatic sac, isn't working right, faulty drainage, essentially.
Or both, I suppose.
Or quite possibly a combination of both, yeah.
So one big idea is this faulty absorption by the endolymphatic sac. Makes intuitive sense if the drains block things back up.
Precisely. And they've shown this in experiments. If you obstruct the sac, you get hydrops. Plus, in actual surgeries on the sac, in Meniere's patients, they've sometimes seen poor blood supply, ischemia, which suggests it wasn't absorbing properly. Yeah. And here's where it gets really interesting, thinking about the attacks themselves. The theory is that this constant distension can eventually cause a tiny rupture in Reisner's membrane.
A rupture inside the ear.
Yeah. And when that happens, the endolymph, which is rich in potassium, mixes with the other inner ear fluid, the perilymph, which is rich in sodium. This sudden chemical change, this kind of ionic shock, is thought to be what triggers that sudden, violent vertigo attack.
Wow, okay. A chemical storm in the inner ear. That's quite a mechanism. What about the other theory? There was one about vasomotor disturbance.
Right. So that one connects to the nervous system and blood vessels. The idea is that maybe overactivity in the sympathetic nervous system, your fight or flight response, causes spasms in the arteries supplying the inner ear. Or maybe a lack of oxygen, anoxia, affects the tiny capillaries in the styria vascularis, making them leaky, which could lead to more fluid production. It's all about disrupting that delicate blood flow and fluid balance.
And then there's the allergy connection, which seems surprisingly strong. The inner ear acting like a shock organ.
Yeah, that was striking, wasn't it? That nearly 50% of patients might also have inhalant or food allergies. It suggests the immune system could be involved, maybe triggering inflammation and excess fluid.
It really points towards it being multifactorial, doesn't it? Like several things could be contributing.
Absolutely. You know? And there are other theories, too, like sodium and water retention generally causing fluid buildup.
You know, amidst all these potential causes, one thing really stood out to me for its, well, practical side. Hypothyroidism. The text mentioned about 3% of cases might be linked to it. Why is finding that link so important for a patient?
Oh, it's hugely important because unlike a lot of the other potential factors where we mostly just manage symptoms, hypothyroidism is treatable. If an underactive thyroid is the root cause for someone's Meniere symptoms, treating the thyroid condition with hormone replacement can directly improve or potentially even resolve the inner ear issues.
That's a massive difference in outcome.
It really is. It just highlights why doctors need to do a thorough workup, looking beyond just the ear itself. And then you also have autoimmune issues and maybe past viral infections like measles or mumps being suggested as other possible triggers.
It underlines that need for comprehensive care. Okay, so shifting gears a bit, who typically gets Meniere's? Are there, like, demographic patterns?
Yeah, there are some general trends. It most often shows up in people between, say, 35 and 60 years old.
Okay, middle age mostly.
And interestingly, it seems to affect males slightly more often than females. Usually it starts in just one ear.
But it can spread.
It can, yeah. It's not unusual for the other ear to become affected too, maybe after a few years.
We've talked about the what's inside the ear and the why it might happen. But what does it actually feel like day to day? That vertigo sounds just awful.
It really can be debilitating. The vertigo usually hits in attacks, and they often come on very suddenly.
Like no warning.
Often very little warning, yeah. People describe feeling like they're spinning or the whole room is spinning around them. Sometimes it's more of a weird to and fro or up and down sensation. And these attacks can happen in clusters. You might have several over a short period, and then suddenly they stop. You go into remission, which could last weeks, months, maybe even years.
That unpredictability must be so stressful.
Hugely. And the vertigo itself is often paired with other lovely symptoms like nausea, vomiting, ataxia, which is trouble with balance and walking, and nystagmus.
Yes, nystagmus. Those are the jerky eye movements, right?
That's right. And in really severe attacks, you can get what are called vagal disturbances. That's your nervous system going into overdrive, things like abdominal cramps, diarrhea, breaking out in a cold sweat, looking pale, even a slow heart rate, bradycardia.
Wow, just a total system reaction.
Pretty much. Now, while attacks are often sudden, some people do get a bit of a warning sign. Maybe that feeling of fullness in the ear ramps up, or their tinnitus changes pitch or intensity, or just a general feeling of unease.
A kind of premonition.
Sort of. And living with that constant fear of when's the next attack understandably causes a lot of emotional upset and stress, which ironically people used to think caused the disease, but now we see it more as a consequence.
That makes sense. Are there any really unusual triggers or ways it shows up?
Yes, absolutely. There's something called the Tullio phenomenon. It's quite rare, but really fascinating.
Tullio phenomenon, what's that?
It's where loud sounds or noise can actually trigger an attack of vertigo.
Wait, seriously? A loud noise makes you dizzy. How does that work?
Remember how we said the saccule gets distended and might press against the stapes footplate?
Yeah, the little sound-transmitting bone.
Right. So imagine like swollen, sensitive saccule is right up against the stapes. When a loud sound hits the eardrum, it makes the stapes vibrate strongly. Because the saccule is touching it, it gets directly jostled or vibrated by the loud sound. And since the saccule is part of your balance system, that sudden, unexpected stimulation triggers vertigo. It's like the sound is physically shaking your balance sensor.
That is incredible. What a specific, weird mechanism. Okay, let's talk about the hearing loss. The text said its fluctuating nature is really characteristic. It gets better after attacks, maybe even normal in remission.
That's often true, especially early on. The hearing can definitely fluctuate. But the downside is, with repeated attacks over time, the hearing might not recover fully each time.
Ah, so it's like each attack chips away a little bit.
Exactly. Some permanent hearing loss can accumulate with each episode, leading to this slow, progressive deterioration that doesn't bounce back.
And it's not just about volume being lower, is it? The text mentioned distorted hearing. That sounds tricky.
It is. People might complain that sounds are just wrong. There's something called duplacusis, where a single tone sounds like a different pitch in each ear. Yeah, or listening to music becomes unpleasant because it sounds discordant, just out of tune or harsh.
That must be really frustrating.
And it gets worse. There's often something called recruitment. This means quiet sounds might be heard okay, but as sounds get louder, they quickly become uncomfortably, even painfully loud.
Oh, so you can't just turn up the volume easily.
Exactly. That's why the text notes that patients cannot tolerate amplification well and are often poor candidates for hearing aids, unfortunately. The distortion and recruitment make it difficult.
Man. Okay, and the tinnitus, what's typical there?
It's often described as a low-pitched roaring sound, kind of like the ocean, maybe. It usually gets worse during the acute attacks.
Roaring. Okay.
Sometimes it's more of a hissing sound, and it might not go away completely during remission periods, like the ear fullness. Sometimes a change in the tinnitus can be a warning sign that an attack is coming.
Right, that fourth symptom, this sense of fullness or pressure, that fluctuates too.
Yes, it often comes and goes, and frequently either accompanies or pops up just before a vertigo attack hits. It's all part of that classic episodic picture.
Okay, so someone's having these symptoms, the vertigo, the hearing changes, tinnitus, fullness. How do doctors actually nail down the diagnosis? What's the process?
Well, the first step is usually looking in the ear with an otoscope, but surprisingly, the eardrum often looks completely normal.
Huh, so you can't just see it?
Nope. Nystagmus, those eye movements, you'd only likely see if the person is having an acute attack right then and there. Basic tuning fork tests would usually point towards a sensorineural hearing loss, meaning the issue is inner ear related, not like a blockage in the middle ear.
And then you move on to more specific tests.
Exactly. Key investigations. Hear tone audiometry is standard. That's the hearing test where you listen for beeps.
Right.
In the early stages of Meniere's, hearing loss often affects the lower frequencies more, so the graph shows a rising pattern. As the disease progresses, the loss tends to become flatter, affecting more frequencies or even a falling pattern worse in the highs.
Okay. And what about electrocochleography? That sounds fancy.
It is pretty specialized, yeah. Electrocochleography, or ECOG, measures the electrical potentials generated inside your cochlea, your inner ear, when it responds to sound.
Electrical signals from the ear.
Tiny ones, yes. Normally, there's a specific ratio between two of these signals, the summating potential, SP, and the action potential, AP. It's usually around 30%.
Okay.
But in Meniere's, because of that excess fluid pressure, this SPO ratio often increases significantly, usually above 30%, sometimes quite a bit higher. It's a fairly specific indicator of endolymphatic hydrops.
Wow, so it's actually measuring the effect of the pressure electrically. That's clever. What about the glycerol test?
The glycerol test is interesting. Glycerol is a dehydrating agent. It basically pulls fluid out of tissues.
Like osmosis.
Pretty much. So the patient drinks a dose of glycerol mixed with juice, usually. The idea is that it will temporarily reduce the endolymph volume and pressure in the inner ear.
And if it does?
If it does, their hearing might temporarily improve. A positive test is usually defined as a specific amount of improvement on the audiogram, like 10 decibels better hearing in a couple of frequency ranges, or maybe a 10% jump in their ability to understand spoken words.
So it confirms the fluid pressure is part of the problem.
Exactly. It can also temporarily reduce the tinnitus and fullness, so it's both diagnostic suggesting hydrops and can give the patient a glimpse of relief, which is nice.
That is neat. Are there other tests involved?
Yeah, often they'll do speech audiometry to see how well you understand words, not just tones. Special tests looking for that recruitment phenomenon we talked about, like the SI test, and often a caloric test.
Caloric. That involves temperature.
It does. Warm and cool water or air is gently flushed into the ear canal to stimulate the balanced part of the inner ear. The response, usually measured by looking at eye movements, nystagmus, helps assess the function of the vestibular system on each side. In Meniere's, the response on the affected side might be reduced.
Okay, quite a battery of tests. And there's a formal classification system, too.
Yes, the American Academy of Otolaryngology Head and Neck Surgery, the AOHNS, has criteria to help standardize diagnosis. Definite Meniere's is the strongest clinical diagnosis.
What does that require?
It requires having 2 or more spontaneous episodes of vertigo, each lasting at least 20 minutes, plus audiometrically documented hearing loss on at least 1 occasion, and tinnitus or oral fullness in the affected ear. Crucially, all other known causes for these symptoms have to be ruled out.
Makes sense. Rule everything else out first.
Exactly. Then there's probable Meniere's, which is similar but maybe only requires 1 definite vertigo episode along with the hearing loss and other symptoms.
Yeah, possible.
Possible covers situations that look like Meniere's but don't quite meet the full criteria. For example, someone might have the episodic vertigo without documented hearing loss, that's sometimes called a vestibular variant. Or they might have the fluctuating hearing loss, tinnitus, and fullness without definite vertigo episodes, a cochlear variant.
So variations on the theme.
Pretty much. And it's worth noting, the only way to get a certain diagnosis is through histopathology, actually examining the inner ear tissue after death, usually. So clinically, definite is usually the highest level of certainty while someone is alive.
Got it. So it doesn't always present with all 4 symptoms firing at once. What are some of these variants?
Well, like we just touched on, there's cochlear hydrops. That's where you get the hearing symptoms, the fluctuating loss, the tinnitus, the fullness, but no vertigo, at least not initially.
But the vertigo might show up later.
It might, yeah.
Yeah.
Sometimes years down the line, the typical vertigo attacks can start.
And the flip side.
Is vestibular hydrops. Here, the person has the classic episodic vertigo attacks, but their hearing tests remain normal. Again, this might eventually evolve into the full picture with hearing loss over time.
Okay, and then there was something really dramatic sounding, drop attacks. Tumarkin's otolithic crisis.
Yes, these are quite alarming. It's a sudden drop attack where the person just collapses, often without any warning, and importantly, without losing consciousness.
Just falling straight down.
Exactly. The description is vivid, feeling like they've been pushed to the ground or poleaxed. There's no spinning vertigo, no change in hearing associated with the drop itself.
Wow, that must be terrifying. What's thought to cause that?
The thinking is it's due to a sudden mechanical disturbance of the otolithic organs, the utricle or saccule, those gravity motion sensors. Maybe a sudden pressure shift causes their membrane to deform abruptly, triggering this reflex collapse. It's not the same as the rotational vertigo.
A completely different sudden mechanical failure. Yikes. And Lermoyer's syndrome. That sounded backwards.
It is. It's a rare variant where the sequence is reversed. First, the person experiences worsening hearing loss and tinnitus. Then they have a sudden attack of vertigo.
Okay.
And during or immediately after the vertigo attack, their hearing actually improves.
Get out. The vertigo makes the hearing better.
Bizarre, right? The idea is maybe the vertigo attack somehow relieves the pressure or blockage that was causing the hearing loss. It's definitely a paradoxical presentation.
That's wild. Now, let's clarify something important. Meniere's disease versus Meniere syndrome, are they the same thing?
That's a really key distinction, actually. Meniere's disease is what we call idiopathic. That means we don't know the specific underlying cause. It's the primary condition.
Okay, the mystery one.
Right. Meniere syndrome, on the other hand, presents with very similar symptoms, the vertigo, hearing loss, tinnitus, fullness, but it's secondary to some other identifiable condition.
Like what?
Things like head trauma, certain viral infections such as measles or mumps, syphilis, an autoimmune condition called Cogan's syndrome, sometimes complications from otosclerosis or other autoimmune disorders. Because we know the why, it's called secondary Meniere's or Meniere's syndrome.
Ah, okay. So the symptoms look the same, but the origin story is different. That's helpful. So let's talk treatment. What can actually be done for someone living with this?
Well, the approach is often stepped. It usually starts with general measures, kind of the first line of defense. A big part of this is just reassurance and education. Helping the patient understand what's happening can really reduce anxiety.
Yeah, knowing is half the battle sometimes.
Definitely. And then lifestyle adjustments. One that really jumped out in the source was smoking cessation.
Oh yeah, you mentioned that. Nicotine causes vasospasm, restricting blood flow, and stopping smoking could potentially be enough for some people.
That's what the text suggests, yeah. For some patients, this may be the only treatment necessary. It's pretty powerful. Other things include a low-salt diet, typically aiming for around 1.5 to 2 grams per day.
Why low salt?
to help reduce overall fluid retention in the body, which might indirectly affect the inner ear fluid levels. Also, avoiding excessive water intake, caffeine, tea, and alcohol is often recommended.
Managing triggers, basically.
Right. And stress management is important too. Things like mental relaxation techniques, maybe yoga. Plus, practical advice like avoiding situations where a sudden vertigo attack would be dangerous, like flying planes, scuba diving, working up high.
Makes sense. Okay, what happens when someone is having an acute attack right now? How do you manage that immediate crisis?
During an acute attack, the goal is really just symptom relief and getting the person through it. Bed rest is key. If they're vomiting a lot, IV fluids might be needed to prevent dehydration.
And medications.
Yes, vestibular sedatives are commonly used. These are drugs like dimenhydrinate, you might know it as Dramamine, or promethazine, prochlorperazine. They help calm down the inner ear signals and reduce the nausea and vertigo.
Like anti-motion sickness drugs.
Similar class, yeah. Diazepam, which is Valium, can also be helpful. It has a calming effect generally, but also seems to suppress activity in the vestibular nucleus in the brainstem, which processes balance info. The source even mentioned a specific intervention. An injection of atropine subcutaneously might actually stop an acute attack in its tracks sometimes. And vasodilators might be used too, like Carbagen.
Carbagen, what's that?
It's a mix of 5% carbon dioxide and 95% oxygen. Breathing it in is thought to dilate blood vessels in the brain and inner ear, improving circulation, which might help resolve the attack.
Interesting. So that's managing the crisis. What about long-term, chronic management, trying to prevent attack?
Medical therapy is often the mainstay here, and it can be quite effective. This might involve continuing with vestibular sedatives, maybe at lower doses, or using vasodilators more regularly. Beta-histine is a common one.
How does beta-histine work?
It's thought to act like histamine in the inner ear, improving microcirculation and blood flow within the labyrinth. Diuretics are also frequently used.
Water pills.
Yep, like furosemide or thiazides, often taken perhaps every other day. The idea is to reduce overall body fluid and hopefully prevent the endolymph from building up excessively.
Right, addressing that high drops.
Exactly. And of course, if an allergy was identified, then eliminating that allergen or undergoing desensitization therapy would be part of the long-term plan. Same for hypothyroidism, treat the underlying thyroid issue.
And the good news, as you mentioned, was that medical therapy alone works for a lot of people.
Yeah, the text stated about 80% of patients can be effectively managed just with these kinds of medical approaches. That's pretty encouraging.
That really is. But what about the other 20% where it's not enough?
For those individuals with persistent disabling symptoms despite medical therapy, more invasive options are considered. One is intratympanic gentamicin therapy.
Injecting gentamicin into the ear. Isn't that an antibiotic?
It is, but it also has a side effect. It's toxic to the vestibular system, the balance part of the inner ear. It's vestibulotoxic.
So you're intentionally damaging the balance organ.
Essentially, yes. It's sometimes called a chemical labyrinthectomy. The gentamicin is injected through the eardrum into the middle ear space. It gets absorbed into the inner ear and selectively damages the balance hair cells.
Why would you do that?
To stop the vertigo attacks. By reducing or eliminating the function of the faulty balance organ, you stop the source of the vertigo signals.
But what's the catch? Does it affect hearing?
That's the major risk. While gentamicin is more toxic to the vestibular system than the cochlea, there's still a significant risk of causing or worsening hearing loss. The stats mentioned were total vertigo control in 60–80% of patients, but hearing loss, sometimes severe, occurring in anywhere from 4% to 30%.
It's a definite trade-off. You might stop the spins but lose more hearing.
Exactly. It's usually reserved for people with severe, frequent vertigo who haven't responded to anything else, and often considered more seriously if the hearing in that ear is already quite poor.
And that microwick thing you mentioned earlier, is that related to this?
It can be, yeah. The microwick is a clever little device for delivering medication to the inner ear over a longer period without needing repeated injections.
How does it work again?
You need a small tube, a grommet, placed in the eardrum first. Then this tiny wick, like a piece of string almost, sits through the grommet with one end in the external canal and the other near the round window membrane, which leads to the inner ear. Medication put on the outer end wicks its way down to the inner ear.
So you could use it for gentamicin delivery.
Precisely. Or for delivering steroids, for instance, in cases of sudden hearing loss. It's a way to get sustained drug delivery right where it's needed.
Very neat tech. Okay, so if medical therapy, including gentamicin, doesn't work or isn't suitable, then you're looking at actual surgery.
That's generally the last resort, yes. Surgical options are typically only considered when medical treatments have failed to control the debilitating vertigo, and there are different types.
Like what?
There are procedures aimed at being conservative, meaning they try to preserve whatever hearing is left. One is decompression of the endolymphatic sac. The surgeon exposes the sac and might remove some bone around it to give it more room, hoping to relieve pressure. Another is an endolymphatic shunt operation. Here, they actually place a tiny tuber valve draining from the endolymphatic sap into either the mastoid bone space or the cerebrospinal fluid space, trying to create a permanent drainage route for the excess endolymph.
Like plumbing for the inner ear.
Kind of, yeah. Then there's vestibular nerve section. This is a major surgery where the surgeon cuts the balance nerve coming from the affected ear, stopping the vertigo signals from reaching the brain, but hopefully preserving the hearing nerve right next to it.
High-stakes surgery.
Definitely. And sometimes ultrasonic energy is used to try and selectively destroy the vestibular labyrinth while sparing hearing.
Okay, those are the hearing-sparing attempts. What if hearing isn't really functional in that ear anymore?
Then destructive procedures might be considered, primarily labyrinthectomy. This involves surgically removing the entire balance and hearing sensors within the inner ear on that side. It permanently stops vertigo from that ear, but results in total deafness on that side.
The nuclear option, basically.
Pretty much. Reserved for severe cases with non-serviceable hearing in the affected ear.
And finally, there was that Meniere device therapy, the low-pressure pulses. That sounds quite different.
It is quite unique, yes. Intermittent low-pressure pulse therapy. It's an FDA-approved treatment.
How does it work?
Again, you need a ventilation tube, a grommet in the eardrum. The patient uses a small, portable device at home, usually several times a day. The device generates cycles of low positive pressure pulses that are delivered through the tube into the middle ear.
And these pressure pulses do what?
The idea is that these gentle pressure waves transmit through the round window membrane into the inner ear fluids. This is thought to help reduce the endolymphatic pressure, maybe by promoting fluid movement or redistribution, or perhaps even influencing the regulation of fluid production by the Strelbias vascularis.
And it helps with symptoms.
Studies suggest it can significantly reduce vertigo frequency and severity for many patients. It might also help with tinnitus and the fullness sensation, and some people even report hearing improvement.
And they can do it themselves at home.
Yes, that's a big advantage. It's non-destructive and self-administered. It's often seen as a less invasive option compared to surgery for people who haven't had success with medication.
That's a really interesting spectrum of treatments, from diet changes right up to nerve sectioning and pressure devices.
It really covers a wide range, reflecting how challenging this condition can be to manage.
So we really covered a lot of ground here. We've journeyed from, that subtle fluid distension deep inside the ear right through to the pretty profound ways Meniere's disease impacts life, its murky causes, the complex diagnostic steps, and this whole array of treatments.
Yeah, hopefully you've now got a much deeper handle on this condition. Understanding that fluctuating episodic nature is key, I think. And the surprising potential causes allergy, thyroid issues, plus that balance between different treatments, from lifestyle tweaks to major procedures.
Absolutely. This whole deep dive really highlights how these tiny hidden parts of our body can have such a massive effect on our whole sense of reality, our quality of life.
It's true, the inner ear is incredibly intricate.
It leaves you wondering, though, what other seemingly isolated systems in our bodies might hold similar keys? Where just a tiny imbalance could set off such widespread, diverse, and really debilitating symptoms. Something to think about.